I'm a cardiologist from a university hospital in Maastricht. This is not to show all my financial disclosures, because I don't have any regarding AL amyloid, but it's to show the interest within our specialty for the disease. Some years ago, the general cardiologist, please correct me, I'm wrong, didn't bother about amyloidosis at all. This has changed tremendously. If you go to a cardiology congress, you will see huge of presentation on this topic. Just to as a hint, right? This is what we are talking about. It's the amyloid fibril. And we know that this has certain toxic effects on the heart, but we probably can appreciate that much of the damage is due to the mechanical properties, because it's very lengthy, it's rigid, and it accumulates in the organs. And if you look at ATTR or AL, it's probably the same concept, because you see accumulation of the amyloid between the muscle fibers. So we don't talk about hypertrophy, which is thickening of the muscular fibers, but there's something in between that makes the heart very thick. And of course, this provides some changes through heart. There are two main stages of cardiac changes that we see. On the left-hand side, you see a nice example of a patient with an AL amyloidosis. And you might appreciate that the left ventricle on the, do you have a pointer? There we go. That's the left ventricle of the heart, is very prominent, and it's extremely thickened. Also, the right ventricle is thickened very much, because it's a diffuse process taking place. It's not like hypertension, which only affects the left ventricle. It's the heart as a whole, right? We do see some valve changes, but mainly in ATTR patient. But it's also very prominent is conducting disturbances. You might know that the heart is a muscle, and the muscle needs an electrical stimulus to function. And this runs via particular fibers, and those fibers can also be changed by those fibrils at various stages or locations of the heart. So the main symptoms we see in our patients are due to heart failure, there's any change of function or structure of the heart, due to atrial fibrillation, which is a very prominent arrhythmia, and due to any other conduction abnormality, such as bradycardia, tachycardia, for instance. If we talk about supportive therapy, we mean that we mainly focus on symptoms. We don't do anything about the disease itself. That's curative. That's like chemotherapy in AL, that's like whatever in ATTR. We don't take care about that. It's just we mainly focus on the symptoms of the patient. Those symptoms we frequently occur are shortness of breath, swollen ankles, edema, weight gain due to fluid accumulation. Patients are tired, fatigue, they cough during night because there's fluid accumulation, they lose appetite, they lose weight, they feel dizzy, they feel a rapid heart rate or irregular heart rate. Those are the common symptoms we see in our patient. Cardiologists love guidelines. Whenever I see a patient with a particular disease, we look at the European or the American guidelines. Unfortunately, none of those advices, recommendations can be applied to amyloid disease, because do you agree?
Yes, absolutely.
All right, thank you. I was a little afraid. All those nice medications that do work in heart failure patients have never ever been tested in amyloids. Still, we use them. So it's more based on experience than evidence. But we don't have anything else. To make it even more complex, and you've heard that, many drugs that we love give side effects, such as the beta blockers. It's a lovely medication. But patients do have hypertension, and they have bradycardia, so we cannot use them. Still, it's a balancing act sometimes, because we do see patients having a tachycardic arrhythmia, so we need beta blockers, and we might follow upon them with Holter EKGs to see where we are regarding the rate control. You've heard about ACE and ARNIs from the nephrologist. Of course, they support the heart, but they lead to hypertension, so they might not be wishful to use. Some medication we use on a regular basis in patients with hypertension, such as calcium channel blockers, seem to bind to the fibrils and make it even worse. There's some discussion about digoxin, for instance, but still we don't know everything yet. The main style will be diuretics, of course, to treat the fluid overload, which is a nice example seen here. We mainly prescribe 3 different categories of medications, such as the loop diuretics, mineralocorticoid inhibitors, or a newer group, new kid on the block, you've heard that, the SGLT2 inhibitors. It depends what we want to achieve, such as get rid of the fluid overload, increase the potassium a little bit, decrease the symptoms. We might eventually combine those medications. We are very good at combining and adding things. Other specialties love getting rid of medication use, but it's the interaction which makes it which improve patient care. We always advise patients to look into their fluid. 2 liters is what we tell our patients. Salt restriction to make the heart a little more easy. It's good for the kidneys. Still, those things might induce hypertension. So balancing it again. I've talked about arrhythmias a little bit. Of course, many patients have a sinus rhythm, which is the usual underlying rhythm of the heart. Some patients may have fast heart rates just to compensate for the deteriorated heart function. Some patients have a slow heart rate. You might stop medication. You might need a pacemaker implantation. We don't implant all the devices we have, because it's like you have to talk to the patient, you have to look at the overall situation, but we are not that easy to do everything we could do. Depends on the prognosis, of course, right? In many patients we see atrial fibrillation, which is due to changes of the left ventricle, of course, the left atrium, because there's high pressure within the heart. And we do see some arrhythmias deriving from the left ventricle also. So a huge variety of arrhythmias we see. Oh, sorry, go on. What you all the times have to consider is anticoagulation, particularly if patients have atrial fibrillation, because this gives a high risk of events, thrombotic events such as thrombotic stroke. Again, some patients might have low platelet counts, may have a high risk of bleeding. So again, you have to, you have to consider every single step you take. Besides this, the treatment I just talked about, you have to look at the patient as a whole. And more or less we are seeing elderly patients that might have high cholesterol, that might have high blood pressure. So take care of that also. Of course, you can think about more fancy things we love, such as PCI, stent placement, whatever. We love placing cardiac valves via the groin. Of course, we do that, but it's not being performed on a very broad basis. So it's every single time you do that, you have to think about, and it's an individual decision you take, right? There are some case reports on cardiac transplant or assist devices. Of course, you have to assure that the underlying disease is treated as well. It doesn't make sense to give a patient a new heart while the amyloid disease is going on. That's not the solution. What we see, of course, is that weight loss is not always due to fluid. Many patients do suffer sarcopenia from sarcopenia, which is loss of muscular mass, of muscular function. That's an extreme example, of course, but at least from my perspective, all those patients do benefit from cardiac rehabilitation as a whole. There's like training, because if you talk about condition, it's not the heart only, it's the lungs, psyche, whatever you can address with a rehabilitation program is useful, right? Having said that, we are talking about a whole group of cardiologists that see those patients. I'm not standing here, I'm a more representative of a whole group of cardiologists dealing with those patients. Talking about a specialist in heart muscle disease, you're talking about a specialist in cardiac arrhythmias, you're talking about a rehab specialist. It's just a bunch of a big group of patients. And of course, talking about supportive therapy, you have to think about potential side effects of the curative medications you give. It makes it even more complex. To be able to cope with those problems, we set up a local network, of course, and there's in the background, of course, a national network in the Netherlands, which is probably in parallel to any other country. Thank you very much for your attention.